Welcome to Lupus QD Clinic. I'm Jack Cush with Room Now. Today's case is early lupus. A 29-year-old Latin female comes to me after she went to the emergency room 2 months ago. She presented at that time with 2 months of pain all over with arthralgias in her arms and her legs. In the ER, she was found to have some swollen joints, pancytopenia, was given IM Solumedrol and Toradol for pain and sent home on ibuprofen. In the 8 weeks prior to seeing me, she tried the ibuprofen but couldn't take it because of nausea and vomiting. Again, 2 months ago, she presented with morning stiffness. She had Raynaud's. She had 2 babies in the past, but no history of miscarriage. Her review assessment was positive for back pain, fatigue, myalgia, weakness, hair fall, and occasional rash on her arms and legs. She had dusky fingers. She had a number of tender joints, more than a dozen, but they found only a few that were swollen. And labs done at that time showed an ANA positive at 1 to 1280 in a speckled pattern. ESR was 35, white count was 9.7, H&H was 10 over 32. Platelet counts normal 194,000, but lymphocytes were low at 631. So she had lymphopenia and a positive ANA. Her metabolic profile was normal, creatinine was 8, no LFTs. When I saw her, her pain was 8 out of 10. She had fatigue. She had myalgias. She was noticing hair on the pillow when she would wake up in the morning. She said she was having fevers up to 101 and occasional night sweats. She had biphasic Raynaud's and 5 pounds of weight loss. She had a clear-cut malar rash with a sparing of the nasolabial fold, and she had swollen fingers with PIPs that were swollen. TJC was 12, SJC was 8, MCPs, PIPs were all involved. Labs showed an ANA and a strongly positive double-stranded DNA at 6,190. Now she's leukopenic with a white count of 3 and a lymphocyte count of 700. Platelets are down to 114,000. She has 2+ proteinuria on dipstick and hematuria. Her C3 and C4 are about half their normal value. So this is a gal who has really relatively early disease, but she is active in skin and joint and her kidneys and her serologies. And the question is, how should she be managed? Again, I think at this point, now this would happen a few years ago when I saw her, I didn't do a kidney biopsy. The lesson from this month's campaign on Lupus Unlocked is strongly in favor of getting a renal biopsy to know exactly what you're dealing, to better guide your therapy in line with current thinking, in line with the recently released ACR guidelines on lupus nephritis. I did give her high-dose steroids, 60 milligrams a day, and got her down to 5 milligrams a day after about 4 months, slower than I would have wanted to. She went on hydroxychloroquine. The early argument when I saw her was, and this was around the time that belimumab, I think, was first coming out, was mycophenolate versus cyclophosphamide. She went on mycophenolate and did very, very well, but she had to go on birth control because we worry about mycophenolate. And now, if she's having problems going forward, we could consider, based on biopsy, based on picture, some of the newer drugs, including anifrolumab and belimumab, and also voclosporin, and not have to think about cyclophosphamide in her. But I want to talk about early. And early is a problem in lupus. There are significant delays in the diagnosis. In some series, it's up to 50 months, 5 years from time of symptoms to the time they get diagnosis. I would say, and others who are expert in the field would say, that the referral and early diagnosis of patients is a gigantic, still unmet need. Because early intervention and early diagnosis is going to establish the future trajectory of their disease. And if it's going to take 5 years or more, or 2 years or more, the patient's going to incur damage and be in trouble. There are a number of reports out there that show that when patients are diagnosed earlier, they have lower flare rates, less disease activity over time, less damage, better quality of life measures, less healthcare utilization, and lower overall cost of care. It's also been shown that in things that you worry about, including cardiac complications and whatnot, the risk factors for all of that is present in the first few years. And again, the earlier they're diagnosed, the earlier you're thinking about these things and intervening as early as possible. So luckily, this gal has done well and hasn't had problems with joint damage over time. Her proteinuria did go away on with aggressive management. Whether or not she needs a future biopsy, I think I would now consider it in the case of a new change in her renal status or in her overall activity of her lupus. But again, this QD clinic is really about we need to push for earlier diagnosis. And since that means that your referral base needs to refer to you more aggressively, I think you should be marketing yourself as with a letter to all primary care doctors, all OBs. I am expert in lupus. Send me your early lupus patients who have a positive ANA. I would be happy to evaluate them. This is how you get early lupus patients, and this is how you make a difference in their outcomes. Tune in for more QD Clinics.